Hello and welcome. My name is Taiwo Adedeji and I will be running this lecture, and it focuses on the NASS framework and how the NASS framework is used for technology supported implementation. Just a bit of background. I'm a lecturer and also I'm an active researcher. I work in the health informatics space. I had my education in the University of Portsmouth, and I've worked in different roles within the industry as well. At the end of this lecture, and the one you've had before, you should be able to demonstrate an understanding of how technology is being implemented within the health and care context. So when implementing digital health interventions, and this could be a new project or an improvement, a form of improvement or incremental project, there are different factors to consider, which includes how complex the intervention is and who is going to adopt it and how the adoption is going to play out. Also, there are different frameworks or theories to use in guiding such implementations. And also, since there will be complexity in one shape or form, do we eliminate the complexity or do we reduce or manage the complexity? So we would delve more into these factors. When talking about complexity, there is a need to understand the words simple project, complicated project, complex project. For simple, there are few components, and those components are also predictable, and it's easy to implement such simple projects. Now, when it comes to complicated projects, there are many components and they're largely predictable. However, with complex projects, there are many components interacting with each other. At the same time, how those interactions occur over time, it's very vital. There is a definition from Kohn and his colleagues of complexity being a dynamic and constantly emerging set of processes and objects that not only interact with each other, but come to be defined by those interactions. And it's worth to note that complexity doesn't just apply to the technology intervention, but it applies to the system or the context in which the intervention is going to be implemented. And we know about organizations, how there are different components interacting with each other within, whether you have the healthcare space or in any organization we might be talking about. Adoption is important. Now, there's a quote from Greenhalgh that talks about the more complexity there is in the system, the less likely the technology is to achieve sustained adoption across the system, and the more likely it is to be abandoned. Now, we all work in either in the primary care or the social care sector, or in secondary care, which the hospitals. There are some systems that you're using that are bringing up issues. So sometimes when these issues persist, some staff get fed up of it, and it's either they are used suboptimally or they are abandoned altogether, depending on the experiences of the users. So adoption is very crucial. Now, I haven't discussed about the complexity of health IT projects and how likely they could be adopted or not, or abandoned in the short or long run. Frameworks are tools or are basic structure to adopt in guiding implementation. So what this framework does is it helps to highlight different organizational elements, and it helps to put those elements into context when implementing the technology, because the technology would not be existing by itself. So there needs to be that framework to guide such. And one of those framework we are mainly considering in this lecture is the NASS framework, so which has been proposed and a lot have been written by Greenash, who happens to be a professor of primary care here in the UK. And so the NASS, NASSS, stands for non-adoption, abandonment, and challenges to scale up, spread, and sustainability of technology-supported change efforts in health and social care. Now, this is a framework. It is not a theory, but it's coordinated, brings different theories, relevant theories together to help in writing a narrative of how to implement digital health interventions. Now, it's a theory-informed map which shows different aspects of complexity in the project and even in the organization. Now, the core theory that underpins the NASS framework is the theory of complex adaptive systems. And this theory are these systems, complex adaptive complex systems, are characterized by fuzzy boundaries. The interacting agents operate according to internal rules that cannot always be predicted. Such systems interact, adapt, and co-evolve with other systems. So, and such systems are systems that some of us, or I would say most of us, must have been interacting with, whether consciously or unconsciously. Now, the NASS framework has different domains, 7 in particular, and it's got subdomains as well within each domain. Now, the first domain is condition. For every technology project, whether it's a new system or a new system completely, or an improvement system, it mostly would aim towards supporting a particular illness or condition, so to speak. Right, and the technology itself, it's one of the domain, and all the things under that, so which deals with performance and, performance and features of the system, and more of all of these components, will be addressing them, each of them, and also the value proposition. So what is the technology bringing to the organization? Who are the adopters, people who are going to use the system, and also the organization in which the technology will be implemented, and what is the wider system that would be affecting, whether positively or negatively, the technology being implemented, and how is this technology going to be adapted over time, embedded into the system. So let's start with the first domain. Now, for each domain, there are theoretical influences, or there are different theories that adapt or that influences, if you like, the domain, and also there are different complexity around each domain. So for this first domain, which is condition, so we're looking at illnesses, for instance, diabetes, and I'm sure this is largely your space as healthcare professionals, and all the condition things surrounding this condition. Now, there are different theories, which we have examples of the biomedical and epidemiology theories of disease. And also we have the pharmacological theories, which deals with the drugs being used for such conditions. And also theories of illness that looks into the nature of illnesses. Now, the complexities around this, when the condition is metabolically volatile, for instance, you have sepsis, which has to deal with the long-term condition in the blood, and also you have conditions that are largely unstable, like alcohol dependency, and I'm sure you have different examples to fill that up. Also, there are conditions that are unclear or poorly described, which also could lead to associated comorbidities and polypharmacy. Now, there are different influences as well, which range from socioeconomic and cultural factors. And this could be like ethnic minorities, some illnesses and conditions are prominent in different society or societal statuses. Now, the second domain, which is the technology domain. Now, these involve different technologies being used. So you have the electronic health records, you have, sometimes you have the patient-facing portals and mobile applications and devices. Now, there are other technology tools that aren't very specific to health, that are generic, which includes, like hardware, software application like Office, Microsoft Office, Office 365, and other applications that could stand as a technological improvement. So the theories influencing these areas, like the socio-technical systems theory that deals with how technology is being adopted within the workplace, and technology adoption theories as well, like for instance the TAM, which is technology adoption model, which deals with how you use technology over time within the organization, and also the normalization process theory, which we'll be looking at towards the end of this class. And that has about 4 constructs that deals with how people understand the technology and how they evaluate it at the end. And user-centered design theories deals with the usability, the user experience of the technology being implemented. Now, the different complexities here with the technology domain, how does the technology perform across organization? How proficient are the users, whether the staff and patients are able to use it, and also the knowledge being derived from the technology. Can the users trust that knowledge? For instance, the clinical decision support system. So when the alerts is coming up and any message that's helping with either the drugs to use for a particular condition. Now, is there a trust in that? And can that be contested as well by the clinicians? And the technology supply model is also a complexity that is involved in the technology domain, and who owns the IP, who owns the intellectual property. So there are different issues that could rise around that as well. Okay, the third domain, which relates to the value proposition. So, and this could be from the supply side, it could be from the demand side. So the healthcare organization, what value are they deriving from the technology implementation? And the patients, what value are they deriving? Now, in the case of private healthcare system, so the health insurance providers, what are the values they're deriving from the system? And that leads to the transaction costs theory, which was developed to explain the governance implications of costs that constitute friction or a barrier to otherwise desirable economic or social exchange. And often, the primary value of a technology is reduction in the transaction costs and also reducing frictions on the patient-provider interface. For example, patient-facing digital health innovations such as the video consultations and apps designed to support self-care in the home and help patients to locate or even pay for the rate of laboratory services in their vicinity. So that in itself, sometimes could bring difficulties in writing out a business case and how that business case can be justified. And there are different assumptions that comes around that. Is this going to reduce the cost of attending to patients? Will it, add more cost? And how are these costs being redistributed, the cost of innovation being distributed among different parties interested in the project? Now, the adopters, now these are the staff, the patients, and the carers who will be expected to use the system, the technology, and they could also refuse to use it or find that they are unable to use it all at once. So social learning theory, for example, the on-the-job training. So this emphasizes on on-the-job training or the use of role models that would help in using the technology when it's been introduced into the organization. So also the structuration theory looks into why do health professionals, why do they refuse to use the technology being introduced? And the burden of treatment theory emphasizes on, the shifting of responsibility from the clinician to the patient. So, for example, if an app is being introduced, to help patients to, let's say, monitor their blood pressure, that role is being shifted from the care provider to the patient. So that burden has been shifted to the patient. So the theory looks into issues like that. Now, the complexity that arises in this domain when the users are not interested in the technology or they're not even using it. Perhaps they don't know how to use it. And also there are different threats that the technology could bring. For example, when the users perceive that the standard of care they're delivering, it's been reduced by the introduction of technology, and also, the perception that the use of the technology is going against their code of conduct. So these complexities needs to be addressed, or I would say narrated, when implementing a digital change. Now, the fifth domain, the health organization, and mentioning that, just brings about, the complex nature, the interactions that goes on within the healthcare organization. For instance, the features of different organizations that either support innovation or not. Now, these needs to be brought into account. And there are a host of theories that really address this issue. So the NPT, which is the normalization process theory, which we'll be looking at shortly. You have the organizational structure and the climate, the theory of organizational structure and climate. And this is where well-documented findings that well-led organizations with flat hierarchies, devolved decision-making, slack resources, and a risk-taking climate find it easier to innovate than those lacking these features. Now, the theories of absorptive capacity looks into the preconditions for capturing knowledge from outside the organization and disseminating it internally. The theories of organizational readiness looks at the notion of innovation system fit and the potential wrecking power of strategically placed opponents. So when the organization, other organizations as well, use technology and there's a bit of competition around that. So the theories of incremental versus disruptive, and that's also common, where some disruptive innovation have been introduced. For example, the rip and replace school succeeds far less often than a more incremental approach to change. So it's changing things completely or doing it slowly in an incremental manner. So this introduces a lot of complexities. Is the organization capable of innovating? Are they ready for the technology? What's the funding peculiarities around the adoption, and what are the disruptions that the technology will bring in the day-to-day routine? And also, what is the magnitude of work to be done, to ensure the changes happen? Now, we're getting to the last few domains. The domain 6 talks about the wider system. So what are the external factors that could affect the uptake of the technology? Now, there are social, political, technological, and economic factors all around. Now, the new institutional theory proposes 3 institutional pillars, which really applies to this domain. So the regulative relates to the laws, regulations, and contracts which stipulate what must happen. Now, the normative pillar talks about the professional and societal expectation about what should happen, and the cultural cognitive looks into mental models about what generally does happen. So how people think that the technology should be adopted to, for simply it's people's expectation, people's thoughts about the technology. So, and that those perceptions sometimes, most times, could be negative about innovation, and this could come from policymakers, could come from professional regulatory bodies, and also the general society. So these all factors affect the uptake of technology. Now, the final domain is crucial because sometimes the technology is taken on board, but does it stay the test of time? Does it last? The people, the users, they continually use it. So that shows that there needs to be that continuous embedding and adaptation of both the technology and also the organization over time. Now, the common, well, I say common, it's been around the theory, which is the diffusion of innovations. So the diffusion of innovation, relates to the spread of the technology in question, how it is being used over a period of time, and how it is being adopted by different aspects of the organization. Now, there's also the organizational resilience, where there could be a major mishap with the technology. How is the organization going to bounce back if the major tools they're using, technology tools they're using, that takes all the system in place? So, for instance, if the EPR being used breaks down, now that would affect the entire, let's say, hospital or the care home or the GP. It affects the operations going on. So if that reoccurs from time to time, so how does the organization bounce back? Because of the dependence on that particular system. So the inability of the technology to adapt to changing context, and we know that the health system is rapidly growing. Technology is being used at every aspect of the health system. So the organization's lack of resilience would really put them in a very interesting position to carry on with the technology advancement that's occurring in every sector, which includes the health sector itself. So moving on to a real life example on a project. So we need to look into the 7 domains and how this has been reported. Now, the condition in this example, the support HF, which is support heart failure project, the condition that was looked at was the heart failure. And heart failure is common among adult population. Also, it's common within the ethnic minorities and people from poor backgrounds. Now, these are complexities around that. And for example, comorbidities. Someone with heart failure might be dealing with diabetes, might be dealing with high blood pressure as well. Now, the technology that was introduced in this project is telehealth, in particular the biomarker monitoring tools. And the tablets were used as well. And this was developed using the co-design methodology. And there's a web portal that was used to display the results of the clinical trial that was conducted for the project. Now, the value proposition. So the implementers of this, or the owners of this project, initially had a plan that community nurses would be able to take on more patients. So from 35 that they were handling, in terms of traveling to each of the patients' home, to up onto 200. And this was the initial business case, that there will be that higher caseload. At the same time, they thought that since the patients will be using the telehealth tool, it will be easier for the data to be processed remotely. So the nurses will be in the hospital just processing the data that is being supplied by the patients. Now, for some reason, there was a slow recruitment, for the trial. Not many patients came on board for it. And the transaction cost, because some patients were feeling that, maintaining, not even the patients now, the hospital were concerned about the cost of maintaining the tools, the telehealth tool in the homes of the patients. So they found that quite complex. And the adopters of the system, the staff in particular, which are the heart failure nurses, some were interested in engaging in the telehealth tool, and some were not very, very interested in it. And this was due to some previous experience they've had with telehealth. Also, some perceive from the research, some of the staff perceive that this would threaten their job, because if the technology is doing most of the job, then they might not have their job at the end of the day. So, and some also feel that this tool doesn't allow them much time with their patient. And even the patient as well had mixed views about adopting the system, because there's the shifting of responsibility, to the patient. And you have some very sick patients who see this as a burden on them. They're very sick, and at the same time supplying their heart failure, heart rate, and blood pressure. That was a lot for them. So the fifth domain, which is the health organization, I would say this system was focused on hospitals, and in particular the cardiology unit within the hospital. Now, there was a good feedback from the leadership, or I would say good support, regarding the introduction of technology, and there were some Slack resources as well that was made available. However, the tool could not be integrated to the larger hospital, and knowing that the heart failure services are quite complicated, because there are different hospitals and different services. I mean, from GPs to hospitals, and even to care homes as well. They deal with these heart failure services. So it's quite complex to integrate such a system together. The wider system, this innovation came when there was a strong policy push for telehealth initiatives, and that led to the speed in adopting the system. Now, even at that, some internet issues occurred for remote areas, and also there was the relation between organizations, the issues around that as well, which still relates to, how the heart failure services, it's hard to come by. Now, the final example, which has to do with, embedding the system, or final domain, which has to do with embedding the system over time. Now, the staff, based on the qualitative research that was done, some staff really wanted the change to go on, the intervention to go on, because they liked it, it helps their work easier. But at the same time, the customization of the tablet technology wasn't sustainable because of its limited scope. And also, some staff were quite pessimistic about the future survival of the technology. So those complexities played different roles in this example. Now to normalization process theory. Now, this theory is an implementation theory. It's in the class of implementation research, and it's helpful for introducing, or I'd say evaluating, projects that are yet to be done, which is, for example, introducing a new APR system, and also for evaluating, it's useful for evaluating projects, health IT projects that are currently in use. So both prospective and retrospective planning is always useful for that. And when implementing a change, a technology change, so that could be a new system entirely or improvement project, there are 4 constructs that the MPT proposes. So one has to do with the coherence, and also the cognitive participation, collective action, and reflective monitoring. So the coherence has to do with how people understand the intervention and the practices, how it's been embedded in practice. While the cognitive participation talks about the work that other people will do to relate with the practices around the digital health intervention. And with collective has to do with the teamwork. What are the actions that will be carried out in initiating the implementation into their day-to-day work, and how the evaluation, the reflexive monitoring that deals with the work to be done in evaluating the impact of the technology in practice. Now, for control theory, now it has its roots in cybernetics, and it's like a 1982 paper from Carver and Shea, I'll say Skia. Now, this relates to humans and systems. So what's their behavior around the technology? And there's a system, so which is called the negative feedback loop. And this negative feedback loop, it's still part of what is used in cybernetics. And you could see from the diagram from that it proposes that behavior is regulated by a negative feedback loop in which the agent compares the perception of its current state against a goal, the goal state, and will strive to reduce perceived discrepancies by modifying its behavior. So that in practice, especially in health informatics, the audit and feedback, it's a tool being used within the control theory, and that's often reported, and which deals with one part, deals with the quality indicators. So for instance, how is the quality of care? How is being enhanced? Is that being enhanced? And also how the comparison between the target quality and the observed quality of care. So this is quite useful theory to think about. Also, the distributed cognition. So this looks more into how information is being processed within a socio-technical system. A socio-technical system, which is how technical systems are used within the workspace. And it should be noted that the workplace, it's complex because that's different components, as I've explained earlier on. And the distributed cognition theory specifically was used, or I would say was extended, to mean dicot CL. So dicot CL means distributed cognition for teamwork, concentric layers. And these concentric layers, I would say the dicot CL has been applied to evaluate the design and use of a blood glucose meter on the ward and to investigate the safety around infusion practices on the ward. So this diagram, which was cited here, displays 5 models which makes the dicot CL. The physical model, the information flow, evolutionary model, the social model, and the artifact model. So the physical model deals with the physical organization, so which is the hospital, the ward, or the care home, which happens to be the immediate environment. And again, this deals with the user interaction with the physical aspect of things. And also looking at the information model, what are the training or the quality control or even the policy that surrounds sharing of information, and how is this relating to the evolving in terms of time, in terms of the years of use of the technology, and who are the people using it? How are they using it? Are they using it collectively as a team, or is there any support being provided for the people using it? And also in terms of the system itself, so how integrated or connected is the system? What are the infrastructure in place to use the system? These are a few things to consider as well within the distributed cognition theory. So that leads us to what our pragmatic decision will be. Are we going to eliminate the complexities or reduce them? In reality, the majority of projects in health and care, especially IT projects, are not simple because of the different interacting factors around it. Now, we can't deny these complexities, and there needs to be a clear acknowledgement and description of this complexity in multiple domains. So referring back to the NASS domains, the 7 domains. So there needs to be that push around highlighting each domain and how the technology we're introducing, fitting into different domains. And as much as possible, we can touch all the 7 domains, or at least most of them. So how do we manage complexity? So is that reduce it, because eliminating complexity would not help the matter, and that's not real, but managing it. And there's a whole lot of ways to manage the complexity. So the people leading the program or the project, how are they encouraged? There needs to be some measures put in place by the management to encourage the people bringing about this change, or the people involved in the change. Now, there needs to be a clear vision written for the program, and getting the views of different stakeholders would really help in developing, jointly developing the way forward. And also there needs to be the discussion around uncertainty, especially when it cannot be resolved. So there needs to be that, identification and also that discussion around it. The frontline staff who would be using this system, they need to be supported and brought in to be engaged. And we can refer to Wendy's lecture last week during the session about involving the stakeholders, and this was around the question and answer session that we had. Also, the frontline staff using the system, there needs to be, funding for them. There needs to be that encouragement and incentive, by the time they're coming in and we're involving them into the system. We need to have some objectives in place to say, okay, we want this and this to be done, but we need to leave how it's going to be done. We can leave it to them to harness what their views are. And also, there could be conflict. So how do we go about this conflict? Manage it in a way that it doesn't spiral out. And there needs to also be some controls in place, for the technology to be adopted over time. And for example, we need to minimize scope creep. So when the objectives have been set, ensuring that we stick to them, that's important. So what are the users' expectation relating to their routine? So how is the project or the technology innovation, how does it work around the users? So there needs to be a study around how the systems is going to be used for their day-to-day activities. So if there's any emergency or any unintended consequences which would come up in reality, so how is this going to be managed and responded to? Now, again, we mustn't forget the context around where this technology is going to be, especially the wider context. We must be aware of the policy, the regulations around our practice, so and how that would affect the uptake of the technology. So all of this helps in managing the complexity. Now, these are few questions for your coursework that you could be thinking about. How do you define the complexity within the project you're doing? What are the features of a complex adaptive system? And in your own case, in your example, what are the areas of complexity within each of the NASS domains that have been highlighted in this lecture? And also, what area or what domain can be reduced, a domain of complexity that could be reduced or managed, and try to bring in the other theories, the relevant theories for your implementation. And what's the evidence that this framework or these theories are going to work in the real world? And these are questions you can think about. Now, in summary, again, most health IT projects or implementations are complex. They're not simple within health and care. And the NASS framework to the rescue to help in coming about a rigorous, I would say, a rich narrative and how multiple influences are there for a complex project. Also, using the relevant theory to guide the technological interventions, and what does success look like? So considering the success or failure of such implementations and how the actors are going to reduce or manage complexity. So these are further reading. So you could look into the change module by the NHS England and Qatar. I think Wendy referred to this in a lecture. Qatar wide transformation project fail. And also there's the paper from Fernandez and Rainey, which looks into managing change in organization, technology change in an organization. And the final one there is the challenges of complex IT projects. So that was a paper from the University of York and looked into I think it was done in conjunction with the BCS, looking into complexity of IT projects and engineering projects as a whole. And yeah, a few references. That's it. Thank you very much. Please, any questions? Send us an email. Thank you.